All right. So today what we're going to cover is mostly upper extremity, but there are some lower extremity material that will be embedded in this. Some of the information needed to get covered wasn't covered fully in the lower extremity, so it's added to this. It's primarily upper extremity, but also we'll have some smattering of lower extremity badness in there. So let's get started here. I'm going to go ahead and screen share. All right, so the shoulder, upper extremity, fractures, dislocations, and the appendicular skeleton. So that's a pretty broad view here. Mostly we'd like to cover the upper extremity, but like I said, there's some smattering of some lower extremity stuff. All right, so our plan of attack here is to go over fractures, dislocations, subluxations, and then also define those. We're also going to go through sprains, strains, and contusions, tendonitis, bursitis, carpal tunnel syndrome, and other hand disorders, common fractures and dislocations, and then a little bit of Q&A. Here we go. So fractures and dislocations. This is also obviously a distal femur fracture. That's some serious badness right there. So when we're looking at fractures, there's a whole bunch of different nomenclature for fractures, which you'll get more in depth with as time goes on. But for just the basic nomenclature here, we've got some different things that we want to talk about. So a fracture is defined as a disruption of all or part of the bony cortex. All right, so that's everything from the periosteum to the middle of that bone. You have green stick and torus fractures, which are an incomplete disruption of the cortex, which would be the coating of the bone or the periosteum. This is usually seen in pediatric patients as the bones contain a higher level of cartilage, so they're more likely to bend and not break. The green stick fracture, obviously, you may have probably heard, it's kind of like taking a green stick, and when you bend that stick and bend it back, you can see where the cortex of that stick was disrupted, just like the cortex of the bone. Or the coating of the bone, also known as the periosteum. So you can see some periosteum kind of bulge here, and here it's displayed in this. This is considered a green stick fracture or a torus fracture. They're not completely interchangeable terms, although very often used interchangeably. So let's go ahead and look through these. Stress fracture or a hairline fracture, or a repeated fracture over time. So this is kind of like a stress fracture or hairline fracture. So there's probably, you can see some calcification here, right there. That's probably where the initial fracture occurred. And then as you see this reactive healing, this is actually calcium that's depositing to form a new kind of covering around that bone or repair the bone. And that's the body laying down new calcium in that halo around the bone. And then obviously a complete fracture here. We've got a double fracture of the forearm, which we'll talk more about later. There's some nomenclature if there's a certain dislocation associated with that. So a dislocation is complete disruption of the joint. The bones involved in the articulation are no longer in contact. So here's the shoulder joint. This is the articular surface of the shoulder joint. And then we've got the head of the shoulder joint here that is obviously out of this acromion process here. So when we look at this, we want to look at when you get a shoulder x-ray, especially if you're, I mean, really any shoulder x-ray should be a two view. So they do a anterior posterior view and then a scapular Y view, and it looks right down that scapula. And why they call it the Y view is because of this Y looking view that you see here. Now, when you see that, you should see the proximal humerus butted right into this joint. If you have an anterior dislocation, which is most common, you'll see it medially. And if you have a posterior dislocation, you'll see it laterally. So posterior dislocation are really seen in two separate things. And then with the caveat of 1/3 that I did see rarely. So the two things that are high yield for boards are going to be a posterior dislocation is either one, an electrocution, or two, a seizure. Those are the two that I've seen that were very obvious in the emergent setting. Plus, they just look weird. They're dislocated, but they don't usually anterior dislocation. They're kind of holding like this, and they're so much more common. But the posteriors just look weird, and the patients usually, either post-ictal following the seizure, or they got some serious tissue damage from being electrocuted. The third type that I've seen for a subtle subluxation posteriorly was a snowboard injury. The problem was the individual didn't really know his complete mechanism, so it was hard to assess, and it was just barely out. So it was difficult to know, like, was that the placement of the x-ray, or was that just an actual posterior dislocation? So it was probably more like a subluxation. It wasn't completely out, but it wasn't completely in. So at any rate, electrocution and a seizure. Two deformities that we really need to understand. These are high yield for testing. It usually follow a dislocation. So what happens is the shoulder joint will dislocate and then relocate and cause this dysfunction. So what you have is a shoulder joint that's kind of hanging out in this in the joint space. The proximal humerus comes out and then slams back in and goes back in, causing the disruption. So a Hill-Sachs, if we look at the head of the humerus, I always remember that. The Hill-Sachs is at the head of the humerus. So it's this deformity here. It's considered a posterior lateral humeral deformity. So when the humerus slams back into that acromion process, the acromion process is kind of hanging over the top. It can depress part of this bone. It's called a depression fracture, and that's a Hill-Sachs deformity. Then the Bankart lesion sits here. You have this articulation process, and laying in this AC joint is this labrum, and it's just that kind of coating, really dense connective tissue that acts as a sheet there to allow the shoulder to articulate. Well, when the shoulder comes out, it'll flip some of that tissue, and it can cause a wing of that labrum to hang out, and that's called a Bankart lesion. So let's see what they look like. So the cool thing is, bad thing for this patient, cool thing for us, is that this patient ended up with both. So you're much more common if you have a Hill-Sachs to end up with a Bankart also. So those are two things that you want to look. But here's the head of the humerus, and this is that Hill-Sachs deformity. And then sitting here in this AC joint, you've got the acromion and the clavicle, right? So in the AC joint itself, you've got this labrum, and this labrum should be nice and smooth here, but it's not. It's got a little tear, and that's called a Bankart lesion. All right, moving on. So a subluxation. So a subluxation is a partial disruption of a joint. So it's not a complete dislocation. It's just a partial dislocation. We see this in nursemaid's elbow. Some of the bones may not contact. You're going to get pain. You're going to get decreased range of motion anytime there is a subluxation. So this is actually what happens with the radius with kids when they get that a lengthening of the arm quickly. They will sublux this annular ligament over the radius, boom, and then it will hurt, and they won't be able to move as well until you reduce this subluxation, which we'll talk about too. So it's just a sprain, right? So what's a sprain? Well, a sprain is a pulling of the ligaments. So here we can stress, this is some some x-rays that are done under stress to try to see, you know, mobility wise and how that joint space is intact. So as you can see, this joint should be able to manipulate with the talus not slamming into the side, but unfortunately it is. So this is a high grade sprain. These are more likely what the orthopedics might do, this type of a stress view. I'm not traditionally doing these, but these are something to be aware that this is something that you can order if you want the radiologist to hate you. Okay, so describing fractures. When we describe a fracture, particularly to our orthopedics, we want to let them know the anatomic location on the bone where the fracture is at. This is really important because it tells us basically how bad the fracture is, if there's going to be a long-term problem, all those kind of things. The orientation of the fracture, different fractures obviously have different prognoses, the number of fragments, the angulation of those fragments, and the rotation. And then again, if it's an open or closed fracture. An open fracture just basically means that there's bone protruding and or an overlying cut or abnormality over the fracture site. So that's often overlooked, as there is sometimes an overlying cut or deformity over the fracture site. Sorry, I have children here today. So that might happen. Okay, so anatomical location. So is it a diaphyseal fracture, a metaphyseal fracture, an epiphyseal fracture, or a proximal distal fracture? So let's look at that in an image. Okay, so the diaphysis is the long part of the bone, right? The metaphysis is the transition from the diaphysis to the epiphysis, and then the physis is the growth plate in between. So epi meaning at the very end bilaterally, meta kind of the transition zone, and then physis is your growth plate. Orientation of the fracture. So is it sideways? Is it longitudinal? Is it a spiral fracture, or is it a transverse fracture? So let's look at those. So transverse fracture here, this is the orientation of a transverse fracture. Okay, so just right across, just like your transverse plane of motion. So this transverse fracture is straight across. You have an oblique fracture. This is a butterfly or a fragment fracture. So one piece is dislodged. A spiral fracture, so it's fracturing through the bone and around. A comminuted fracture, which means that there's more than one piece. And then a segmental fracture. So comminuted, let's see, there's one piece here, one piece here. So comminuted must be more than 1, 2, 3. So there's more fragments. Well, I think the definition is 3. Let me look that up. Comminuted, I think it's 2 or 3. Let's see exactly what the definition is. I don't recall. And some of you are probably yelling it out right now, and that's okay. Comminuted fracture. Comminuted fracture is a break or splinter of the bone into more than 2 fragments. Okay. So obviously, if it's comminuted, we're going to want to get ortho involved. We're going to be a lot more nervous about neurovascular involvement. So simple fractures have 2 main fragments. 1, 2. Fractures are said to be comminuted if there are more than 2 fragments. Oh, I should have just gone ahead in my PowerPoint. Would have found that. Okay, angulation. So angulation of a fracture. So if you have a patient, you always want to assess angulation from, always remember this, everything is always assessed from the anatomical position, okay? So we can't really understand anything about orientation or angulation until we think from the anatomical position. So palms facing forward, okay? And that everything comes from this anatomical position. So the angulation is the angle from normal, which the distal fragment makes in relation to the proximal fragment. Huh? Okay, so what it's saying is if we're looking at a distal forearm fracture, right? So this is talking about a colleague fracture. So a distal forearm fracture is going to, you're in the anatomical position, okay? So if you're saying that And sometimes you can look at the hand too. You don't. So a lot of them are from the anatomical position, but when you're talking about hand and foot, they're a little bit different. You've got the dorsal surface, which is the back, and it's called the dorsal surface because if you look at the hand, okay, there's the hand, and if there was a dorsal fin on here like a fish has, that's always going to be the dorsal portion of the hand. So in my case, dorsal portion of the hand. So that would, if the bone is facing this direction, that would be dorsal displacement. Okay. If it's facing the other, then it's volar. Okay. Now, when you're talking medial and lateral, you can either talk about the bone that it's pertaining to, or you can go from the anatomical position. Same with anterior and posterior. And then varus and valgus are just the internal and external rotation at the foot and ankle generally, or internal and external rotation of the bone itself. So very confusing, not super, super high yield, but good things to know, particularly when you're talking to an orthopedic doc. So let's talk about a little bit more. Here's some rotation of a fracture. So the fractures can also rotate or rotate into a position away from the anatomical position. So at any rate, but so a translation could mean that the bone moves from side to side or rotates as well. So here's a rotation. There's a fracture in this femur and there's an internal rotation at the knee. Here are pronation and supination. When you're talking about hands rotating or foot rotating, we use pronation and supination. So sup, right? You can put sup in your hand. If you're going to pronate, you're going to dump that sup out. Same thing at the foot. Just think about putting sup in your foot. That's a supination, and a pronation going the other way. So just some verbiage to kind of get used to. Open and closed fractures. So closed fractures do not communicate with the atmosphere. Okay, so a closed fracture is your kind of basic fracture. An open fracture or a compound fracture, you know, it's open to the environment, right? So bones are going through the skin. That's pretty easy to get. But we also have to understand that if there's a wound over that site, so say that I hit my head and I've got this huge cut right here, but I also fractured my skull, okay? Even though it might not be the skull fragment that's protruding through the skin, it's still treated as an open fracture. So you still put that patient on Augmentin and other infectious coverage because you treat it like an open fracture. Somebody who's got a boxer's fracture, okay, in their hand, and they've got teeth that protruded through the knuckle, that's treated like an open fracture. So that's just a little caveat to add, because a lot of newbies don't think about that or don't understand that. So it's not only the bone poking through the skin, it's also a trauma to the skin overlying a fracture site is treated the same. So the Salter-Harris classification is really higher yield for pediatrics. We're going to probably just slam this into your head. But at any rate, you're going to have to, for the boards and for the exam, you're going to have to memorize the Salter-Harris mnemonic. And so they've came up with this really pretty easy mnemonic, difficult to see if you're talking about a Salter-Harris type 1 or type 5 fracture. These are pretty tough. However, the other fractures are not as difficult. So you've got the Salter-Harris 1, which is where the growth plate becomes compressed. Okay, that's a Salter-Harris 2. It's basically going right at the growth plate and squishing it. A Salter-Harris 2 is a fracture above the growth plate, and that is going toward the physis, away from the epiphysis. A Salter 3 goes toward the epiphysis. A Salter 4 goes from the physis or metaphysis through the physis and then through the epiphysis. A Salter-Harris 5 is a race of the growth plate, which is kind of what I alluded to with 1. So here's the hard part. 5 and 1 are super tough to either differentiate or to even find. Okay, so 5 is compression, and 6 is, and 1 is either a separation or where the growth plate has slid like this. And so it's really difficult to observe at all, but you can see how this is just blue. And so actually I misspoke. So the Salter Harris 1 is a spreading, there you go, spread of the growth plate, and the E is a crush in the growth plate. So I even get these confused. They're super hard to kind of differentiate, and even harder on an x-ray. But once you know the mnemonic, it's pretty easy. The E, crusher, and the S is separation. And then the R is a reaction of the periosteum. So you can see how this is like the periosteum tore away. Remember that periosteums, they call it the cortex because it's like like the bark on a tree. All right. So if you rip some of that bark away, that would be a R or a type 6 Salter Harris fracture. Okay. So pediatric fractures, okay, we care because they're still growing. They can fracture their growth plates, and that could be bad juju. They could grow asymmetrically. We don't want to see that. So we want to consider comparison films from leg to leg or arm to arm. And we definitely want to think about referring these kiddos to orthopedics. So I had a kid snowboarding, fractured his distal radius, and it was a Salter Harris 2 fracture. I put him in a volar splint and sling. I could barely see it. Actually, my x-ray tech picked it up. And anyway, we treated him like he was fractured just because it was like, yeah, there's a little bit of a torus there, I thought. Turned out to be a Salter Harris 2. So I'm glad that we were able to, I was glad to be able to find that. And I'm super happy for my x-ray tech that actually picked it up before I did. And then the next day we got the report back. Yeah, it was a Salter Harris 2. So we had managed him properly, just had him follow up with ortho, let mom know, hey, keep him in the splint and make sure that you're careful with it because we've got a growth plate that's involved. So that's just something to think about. Okay, so we continue on here with ankle sprains. We've got inversions, sprain. So, you sprain your ankle, right? Everybody's probably spraining their ankle, but we've got 2 different types of ankle sprains. At eversion, where you're going out, so it's considered a pronation type injury. Or when you're talking about the foot and ankle, it's actually considered an eversion, which is pronation, which I don't know why we don't use the same ones, but we don't. And then an inversion, which is much more common, is another injury that we see tons, and that's super common. So obviously this bruising is here over the lateral portion of the ankle. So this was probable inversion injury without even hearing the story, but that's normal. They're going to twist in. You see that quite a bit more often than the eversion. So the ligaments that we're dealing with here. So when we're talking about an inversion injury, the most common ligament that's injured is ATFL, which is the anterior talofibular ligament. You also have the PTFL, which is the posterior talofibular ligament. This is one of the sites that we push on, right? And then we also push on the lateral malleolus or malleolus, however you want to say it. And those are some sites that we use with the Ottawa ankle rules to assess for imaging or not. I mean, whatever I've seen people walk in with the ankle fracture. So you can use the rules or not. They use them in Canada. We're not doing that type of medicine here right now. We're more a litigious society. So you may want to err on the side of irradiating people rather than not. But it is all up to you professionally how you make your judgments. When in doubt, I take a picture because we live in America, and America's a place where we like to sue. So if somebody is suspect at all, you may want to image. If they have an eversion injury, then it's going to be a deltoid ligament that gets torn, disrupted, sprained. And here's that complex. So you don't have to memorize all of them, but that deltoid ligament, okay, is really the one that we're concerned about here on the medial foot and ankle. So what's a sprain? Okay, a sprain is an injury to the ligament, the soft tissues connecting bone and joint. You're going to have pain, right? Swelling, stiffness, maybe inability to bear weight, probably just discomfort bearing weight. A strain is generally resolved. There we go. Generally resolved for a muscle, but it does correlate with tendon involvement. Normally, if I'm diagnosing a strain, I'm talking about a muscle strain. So there's going to be some pain, maybe pain with motion, and there's going to be maybe some guarding muscle spasm, maybe some weakness, swelling, or bruising around the site. So a contusion obviously is where you've got some bleeding into the soft tissue, usually from blunt trauma or a pulled muscle. The microcapillaries rupture causing the bruise, can result in a hematoma. And if it's bad enough, sometimes we have to have them seen by a specialist. Treatments for simple sprains, strains, and contusions. So they've got this mnemonic PRICE. It used to be RICE, rest, ice, compression, and elevation. And now it's protect the joint and then PRICE. So protect, rest, ice, compress, elevate, NSAIDs, all that kind of good stuff. A subungual hematoma kind of ended up somewhere in this area of the upper extremity. So this is caused by trauma. There's this collection of fluid under the nail. The problem is we let this subungual hematoma fester, it could cause the patient to lose the nail and a lot of pain. So of course they can elevate. If it's soon enough, you can trephinate it, which really works well. You basically just either superheat a needle or use these mechanical trephinators pins, but they're basically this little pin with this little like wire tip, and the pin gets super hot at the tip, and then you just go and this opens up and they go, oh, love you. And it doesn't really hurt. You just go till the blood starts to seep out and then pull back. But you have to realize that it needs to occur like like right after the injury occurred. If it's been 12 hours, then that blood is already starting to coagulate. Tendinitis and bursitis. So just like it sounds, right? Anytime you see an itis, you're talking about inflammation. So this is inflammation of the bursa sac, inflammation of the tendons. Super common. Like I said, about 70%, 50 to 70% of my patients come in for musculoskeletal complaints. Good thing I'm good at them because they get diagnosed properly and treated, hopefully. No, I mean, it's common. You're going to see tons of musculoskeletal complaints. You want to get really good at assessing musculoskeletal complaints. You want to get good at explaining things because a lot of times it's just time. So, but you need them to be on your side about this time. So, rotator cuff syndrome, medial lateral epicondylitis, de Quervain's, trigger finger. We're going to go over all these, but they're just a site of inflammation, irritation of the tendon and or the bursa sac causing irritation. Now, I always describe irritation. Irritation is like when you're in a bad mood. So irritation leads to more irritation. When I'm in a bad mood, I'll pick at other people and then they become in a bad mood. And that's how inflammation works in the body. So if you have a tendon, like say the biceps tendon inflamed, pretty soon that inflammation, it causes prostaglandins, it causes this dissemination of signals, and you've got a shoulder that's completely sore and all the tissue around it's inflamed. And that's really how inflammation works. So that's why I feel like when we treat inflammation or bursitis, tendonitis, we need to be aggressive in our treatment because we need to decrease that inflammation quickly so that we can get ahead of it. So nocturnal pain is a common finding with inflammation. You may be able to localize the pain. You may be able to reproduce it with palpation. So the treatment is this RICE therapy, rest, ice, NSAIDs. A corticosteroid injection is usually very helpful as you're putting steroid directly to the site. Also helpful for people where systemic steroids may be contraindicated. You can still inject into the site. Physical therapy referral, and then usually we'll do plain films, and if the plain films don't reveal any malformation, which normally with these don't, then we'll send them for an MRI, but that's usually about 6 to 12 months down the road. So here's your rotator cuff muscles. So the supraspinatus, infraspinatus, teres minor, and subscapularis. So those are your sits muscles. Here's a kind of one of the ways to inject intra-articularly. So with an intra-articular injection, I find the acromion process, I palpate that, and then I'm going to go right over the humerus. So I palpate here, I kind of find this space here, and I mark it with the cap of my needle, and then I clean with iodine, and I use 3 mils of lidocaine without, plus usually 40 to 80 of Kenalog, and life is good. But you got to let them know, hey, you know, give it a couple days to get better. You're going to feel great today because they've got that lido in there, but don't overdo. Medial epicondylitis and lateral epicondylitis, remember, go from the anatomical position. So that's how you get medial epicondylitis is here, lateral epicondylitis there. Golfer's elbow, okay, because golfers have that finish, and tennis elbow. So a backhand in tennis and they follow through in golf. These are just basically palpable discomfort. And what we want to do for these people is, you know, you kind of push here and it's like, oh my gosh, yes, this is a lateral epicondylitis. So what we do is we you know, you can do steroids and NSAIDs and ice and rest. But the bottom line is we've got to decrease the inflammation because it's right there. It's at this tendon attachment point, okay? So if the muscle continues to pull at that attachment site, you're going to really have discomfort, and these can be really pesky. So what we do is we put them in one of these tennis elbow braces, and basically what that does is make an artificial attachment site. So now you have an artificial tendon attachment site there, and it takes the pressure off of this site. Always use the anatomical position. So this would be medial epicondylitis. This is lateral epicondylitis. You always have to go to that anatomical position. So golfer's elbow, notice that as this golfer follows through, right, he's going to, this internal medial part of the elbow is what makes that, because a good golf, when you follow through, you kind of roll your arms over the top or your hands over the top of the club, causes this medial portion of the elbow to become inflamed. So that's called golfer's elbow. And then tennis elbow, you've got that backhand, right? And so then you've got the lateral portion of the elbow that becomes inflamed. So at any rate, those are both pretty much treated the same. Symptoms, right? Gripping pain, hurts when I bring shopping bags in from outside, stiffness in the elbow. You can get some numbness of the ulnar radial nerve, not as common, but I've seen it before. But basically you need to go and pick on that medial or lateral epicondylitis or epicondylar portion and push on it. Always tell patients that's not very nice, but what we do is we try to find pain and then we try to make it worse, just for a way to see if we can fix it. So here's what we're doing. Either one of them, we're creating this artificial attachment site because normally the tendon attaches back here. but we're basically anchoring the tendon now here. And so as we put torque into it, this portion of the band is absorbing that torque, not the other area of connection. So, and then we want to ice it. So I think ice is really overlooked. We say it, but we don't really enforce it, right? Nobody wants to use ice. It's boring. But if we really think about the concept of it, it makes sense, right? So we ice, when we ice, what happens? So we're trying to decrease inflammation. So you've got this inflamed party of grouchy people, right? Well, when we ice an area, what happens? Well, the tissue blanches, it becomes white, right? So that old irritated blood goes away. And then new, fresh blood with new oxygen and nutrients comes in. So as we ice and stop icing and ice and stop icing, we're basically facilitating flow of new blood to the tissue to help repair the tissue and take away all the inflamed, irritated compounds to allow the tissue to heal. Okay, PRP, what's that? Well, it's platelet-rich plasma. So we're seeing that used a lot more to try to repair areas of inflammation or trauma. But platelet-rich plasma is just rich in platelets, stem cells, things like that, white blood cells. So basically what you do is you take autologous blood, so that's the patient's blood, and you put it in a tube. This is really a gross way to say it. And you spin that tube at high velocity. And what happens is the tube will separate. The lighter compounds go to the top. And what happens is you end up with this white buffy coat at the top, and then your packed red blood cells down here. Well, this is what you call platelet-rich plasma. This has lots of platelets, it has white blood cells, it has stem cells. And so then you take this, aspirate this off the top, and then you inject it into the site. So that's mostly done with orthopedic providers, but it is something to think about. X-rays to rule out other etiologies, particularly if they're not improving, and then we can think about surgery in 6 to 12 months. De-Quervain veins, tenosynovitis, very common for some reason after pregnancy. See it in a lot of young women for whatever reason, but it's basically inflammation of the adductus pollicis longus and adductus pollicis brevis. But you've got pain, and then you've got a positive Finkelstein's test, and that is consistent with De-Quervain veins. You can do injections, you can do corticosteroids, you can put them in a wrist brace, basically kind of all these things. If it's recalcitrant, then you can x-ray them, you can refer them to ortho, and if it's not working, then they may consider treatment with surgery. Trigger finger, so you've got all these little pulleys in the hand itself, and the pulley just means like the holes on a fishing rod, okay? And so if one of these pulleys or the line underneath the pulley, being the tendon, is inflamed or impregnated or enlarged, then it can get caught under these pulleys. And so let's look a little bit. But 50 to 60% will respond to cortisone. So we'd like to find the offending portion and inject it. So here's these pulleys. So the A1 pulley sits right here at the palm level, and then you've got A2, A3, A4. But generally it's the A1 that we can mess with, but we don't want to mess with A2 or A4. If that's the problem, we need to send them to a hand surgeon. But if it's an A1 pulley, then we can go ahead and we can get in there, inject with corticosteroid, and call it a day, and hopefully they'll be better. Olecranon bursitis, so it's an inflammation of the elbow, usually in the bursa, but what we need to realize about this is that 1/3 of these cases are septic. So we need to aspirate this. Usually and we need to see what's in that fluid to see if we need to treat it aggressively, like a inflamed, or is it an inflamed joint or is it a septic joint? Obviously, if they are febrile, that's a big deal. So here's just an x-ray. Obviously, there's no bony abnormalities, but there's all this soft tissue swelling and inflammation. We get our lab results. We've got, now this would be from the tap itself, not peripheral blood, but say we tap it, and what we find is this increased white cell count, and the culture comes up with staph. So we're gonna treat it. You can consider doing a sed rate, which should be ESR. This is a Westergren sed rate. It's just a little different, but ESR is what we really mean. A CBC to look for a neutrophilia, most likely in this patient, and then a CRP. So those are probably just going to be elevated, but we definitely want to do blood cultures as well. So our treatment here is to start antibiotics as soon as possible. A 10-day course for a superficial infection. We want to make sure that we're covering skin bugs. So we want to watch for MRSA, right? So we would probably put these patients on Bactrim and Keflex. The thing is, if it's septic, obviously we don't want to use cortisone at all because we don't want to decrease the immune response. But if it's not septic, then we can use steroid. Carpal tunnel syndrome. Okay, so the carpal tunnel is just this tunnel that runs through the wrist, and it's where the median nerve goes through out to the palm of the hand. Pretty common to hear about nocturnal pain, or patients will get this discomfort in their hands and they'll shake their hands out, and that will make it better. That's kind of the classic carpal tunnel syndrome. If it's really chronic, the thenar eminence, so you want to look at that in people. This portion of the palm may be atrophied, so the muscle could be all weak in there. So here's that carpal tunnel, and this is the median nerve. And basically, when they do surgery here, they really do just open this up and cut, and that's it. Yay, give me your 20 grand. So anyways, diagnosis, they can have nighttime pain, possible thenar atrophy. They're going to have a positive phalans, positive Tinels, right? So those are those tapping. This is the phalans, right? And then we had for DeQuer veins, it was the Finkelstein. So there are increased incidence with diabetes, thyroid disease, pregnancy, autoimmune disease, trauma, or basilar joint arthritis. So what does that mean? It basically means if you have inflammation in your body, you're more likely to suffer from this. So the treatment is these nocturnal splints. So they put people in those wrist splints and see if that makes a difference. Because a lot of times at night we tend to do this. We just like sleep like little babies, all rolled up, and so it puts pressure on that nerve. So if we put them in the splints at night, it really helps. NSAIDs. So ibuprofen. I tell people for ibuprofen is the studies show that 400 milligrams every 6 hours, so is the most effective at treating inflammation without giving you side effects. So when you get higher than 400 milligrams every 6 hours, you get a lot more side effects without a lot more benefit. Whereas if you treat with 400 milligrams every 6 hours, you get more benefit with less side effects. Also, corticosteroid injection or a carpal tunnel release, finally, if that's not effective. Dupuytren's contracture, also known as Viking's disease. So this is where this fascia of the palm gets really contorted and scar-like and causes them to have almost this deformity of the hand. So basically what happens is a slowly progressive fibrosis of this, either the flexor tendons, these PAP or MCP joints, or the palmar fascia itself. And it's really consistent with Northern European males. And that's why they call it the Vikings hand or whatever. So also might see it with rheumatism as well. So if it's bad enough, you can take these enzyme treatments to soften the cords, which they're going to inject, or you can have a subtotal fasciotomy, so they dissect that scar tissue. Ganglionic cysts, also known as a Bible thumper cyst back in the day, they're just a fluid collection that can be ruptured. And they used to actually rupture them with a big Bible. And that's why they call them a Bible thumper cyst, but really they're just painful. You can splint, you can try to decrease inflammation, you can do all those kind of things. Basically, if it's really painful, then you have surgery to remove it. But there's that ganglionic cyst. Common fractures and dislocations. So a boxer's fracture. So a boxer's fracture is always that punch the wall or whatever, or someone, and you get a fracture of the fourth or fifth. So we've got the fifth, the fourth, right? MCP. So metacarpal head, okay? So if you've got the metacarpal, so the fifth metacarpal neck or head fracture from hitting something with a closed fist and not having very good form, there's going to be this tilt. So remember, if this is the back of our fish, okay, the volar tilt is going to be forward, okay? So if this carpal bone is more than 30 degrees volar, then we want to think about definitely calling ortho, and we can try to reduce it, basically numb around the hematoma and then put it back in place. You're going to put them in what's called a boxer's splint. So it's basically just a splint that it's an ulnar gutter splint and slight amount of flexion like this, like that, so that they can heal correctly. Definitely talk to your ortho before reducing anything. But the problem is, if it's not corrected properly, then they can scissor and they can have this abnormal movement of the hand. But there's that ulnar gutter splint or boxer splint. So here's some fractures, right? This one we're definitely concerned. You can just grossly see that's closed. So you'd probably measure that, talk to ortho, have your ortho look at that film, and then go from there. Colles fracture. So a Colles fracture is a distal radius fracture with dorsal angulation. Okay, so if it's greater than 10 degrees, we need to definitely think about reducing this. And if it's greater than 10 degrees, then we can leave it alone. So a Colles fracture, right, is dorsal displacement. So here's that dorsal fin of our fish, and we've got displacement that way from the wrist bones. Unstable fractures may need to be pinned. We're definitely going to talk to our orthopedic about this one for sure. So this is going to need to be reduced because we're worried about articular involvement and the chance that this won't perfuse the rest of the bone and their whole wrist will be screwed up. Smith fracture, so that's a reverse Colles fracture. So that's going to be volar displacement. The one thing that you need to know about a Smith's fracture, this is very rare, because think about a Colles fracture makes sense, right? You fall, right? But a Smith fracture is like you fell and your arm did this, which is very rare. So it's usually people that, may not have the best motor skills to catch themselves. So like older people that maybe don't have really good neurologic response, or somebody that has a brain abnormality or had a seizure or something like that may end up with one of these Smith fractures. Intra-articular fractures, right? So if it's intra-articular, we've got a problem because that's where the the joint manipulates. And so we want to make sure that we're referring these people to ortho and that it's managed properly. These joint fractures basically need to be managed so that this articular surface lines back up. So you can see that the articulation is off here, obviously. And after a whole bunch of work, I'm sure they're back to normal. A Jones fracture. So this is the fracture of the fifth metatarsal. So a Jones fracture is one of those fractures that we have to be aware of because there's a high incidence of avascular necrosis if it's not surgically intervened upon. With a true Jones fracture, zone 2 fracture, there's a high risk of non-union. So there's these zones here with the Jones fracture, and the zone 2 is a true Jones. That's likely to have avascular necrosis. Same with zone 3. A zone 1 fracture, you'd still get ortho on board, but less likely to have avascular necrosis. So zone of the tuberosity, zone of the Jones fracture, zone of the diaphyseal stress fracture. Zone 2 is really the zone we care most about with these Jones fractures, and this is why. You've got this blood supply to that fifth metatarsal, and if you're like here, say, then you're likely to cut off that blood supply, and then this portion of bone will all die and can cause basically this part to necrose, and then you're not going to have any function or very decreased function of the rest of the foot. So what do? They put this big pin in there or screw to get those two bony structures together and improve flow. Clavicular fractures. So clavicular fractures are just a fracture of the collarbone, usually from a forceful fall, either onto their side or a Fuchs injury. 5 to 10% of fractures, usually less than 25 years old. 80% of them are in the mid shaft, and we don't really care. Some of them are operative, and we need to know which ones are. Really, they're doing a lot of non-operative fixation of these. You just put them in a sling, have them follow up with ortho. Life is good. Control their pain. Maybe they'll do physical therapy. But if there's a high risk of non-union, we really need to get ortho on board. There's other specific risk factors for non-union, which is female, older, displacement, where it means the bones are not touching. So they're off. The clavicle fracture is so bad that the bones aren't touching. Communition. So there's multiple fragments, or if the patient is a smoker, they're less likely to recover due to the nicotine impeding blood flow to that healing bone tissue. So recent studies support primary role of fixation for completely displaced fractures, when to consider surgery, severe displacement. So if those two fragments of clavicle are in different zip codes, you may want to get ortho on board. If there's more than 1 centimeter of shortening, if they're not, the fragments aren't touching at all, if there's tinting of the skin, if there's an open fracture, or if there's the distal third, so the outer portion near the acromion is fractured, then we really want to think about that. So here's this mid-shaft fracture. We would want to see if this skin's really tinting. We'll probably talk to ortho because that may need to be reduced. Here we've got a comminuted fracture, and you can see there's a big overlap here, definitely more than 1 centimeter of shortening, so that's an ortho. This is an ortho, and this is an ortho because it's that distal third. So all of these guys, we need to consult with ortho, with the exception of maybe this, but I'm thinking that's a pretty good degree of fracture. And so I think they're going to see the orthopod emergently also. So pre-op, post-op, right? They just put the pins there and the plate. Most people don't tolerate this equipment very well. So they've kind of got away. If they don't have to, they don't fix those. Scaphoid fracture, so the anatomical snuff box, right? We really want to be concerned about those. I always push on it. I don't tell them, does that hurt? I just push on it because I don't want to make it a big deal for them. If they're hurting, we'll know. And I don't want to also invite people to make me think that there's a big fracture there, because it's going to change the way that we deal with it. So if there's any anatomical snuff box tenderness, then we need to treat it like it's fractured. Always, if we're suspicious of a snuff box injury, it's always a foosh, so a fall on the outstretched hand. The thing with the scaphoid fracture is that the initial x-ray may not show a fracture. So until that calcium lays back down in that scaphoid bone, there could be a fracture that we don't see. A week later, we re-image it and we see the calcium lay down and we go, oh yeah, there was a fracture. So non-surgical treatment is thumb spica splint for 6 to 12 weeks, depending on the location of the fracture. So what we do with these people is if anybody has snuff box tenderness, you treat them like they're broken. You put them in a thumb spica cast or splint. Then we repeat the x-ray in 7 to 10 days. If it's normal, they're out. If it's abnormal or there's still discomfort, then we can do an MRI. So here's the scaphoid. This is the reason that we don't want to see it, is that if this blood flow here is interrupted, then this portion of the scaphoid can necrose, causing permanent deformity of the wrist. There's a scaphoid fracture that's probably a week later. So see how subtle that is? You don't want to put your license on that if you don't have to. There's a nice one, easy to see. There's a fixation of it. All right, complications, avascular necrosis. We just talked about all of that. Good. Okay, Skiffy. So we'll review Skiffy next week also when we go over peds, but slipped capital femoral epiphysis. So basically they call it the ice cream falling off the cone. So you can see this nice kind of angle here, but then here, when we look at that very head, so here's the epiphysis is right here, and it's starting to slip. And you can see that the neck of the femur has a very strange relationship to the head, and that's a Skiffy, and that will be fixed by internal fixation. So we would follow up with ortho. They're going to have a good history for it. And they're going to fit that demographic group, which we'll talk about more next week in peds. So non-union, when a broken bone fails to heal, it is called a non-union. It can form pseudoarthritis between the fragments. It can also cause avascular necrosis. There's a few sites, so the femoral neck, the scaphoid, what did we talk about? Jones fracture. Risk factors for non-union: fracture stability, the blood supply, smoking, diabetes, and vascular disease. So if somebody's got peripheral vascular disease, we want to treat them like a smoker. And then their nutrition, right? If somebody is really malnourished, then they're going to have a harder time healing. So there's this nasty hip fracture here. Oh, baby. So that's going to be internal fixation for sure. And there you go. So, and look at this piece. Like, don't worry about that. He'll be fine. Okay, gamekeeper's thumb. So gamekeeper's thumb came back from these Scottish gamekeepers. I forget what they used to do, break some chickens' necks or something. But anyway, they would cause a ligament to tear in the thumb. There's a elasticity of the UCL, which we'll talk about, pain with grip and pinch function. I haven't seen this a lot, but you do see it in skiers when they fall on their ski pole. They'll disrupt that ligament as well. So here's that ulnar collateral ligament. So what happens is you get this hyper extension at the thumb joint, causes that to tear, and then you can get an avulsion fracture. And that's either called a skier's thumb or a gamekeeper's thumb, but it's basically that mechanism of pressing the thumb. So if you were in the anatomical position, right, you would be pressing that thumb proximally, or I guess in this position, it would probably be, what would they call that? Cephalically toward your head, right? Or up proximally. Anyway, so you're adducting aggressively with force, and that causes a fracture, or it can cause an avulsion fracture, but a torn ulnar collateral ligament Treatment is non-operative if it's a stable fracture, so they're in a thumb spica splint or cast for 4 to 6 weeks. And then if it's completely ruptured, then they'll probably go in there and fix it with the ORIF, which is a open reduction in internal fixation. You can have these complicated lesions after with some aponeuroses, so that's just something that you need to keep in mind. Mallet finger. So mallet finger is the very distal portion of the your DIP. So distal interphalangeal joint has a tendon rupture or something from a blunt force. So I've seen kids that, like catching a basketball or football, and they'll have that. They'll think they've sprained their finger, and then 3 weeks later they show up in your office. But basically, you want to get it back in place with a splint, and then send them to ortho because they may need operative treatment. Basically, they need evaluation, because if splinting works, then you can leave it. But if it doesn't, then they got to do an ORIF. So there it is. The mallet finger is the very distal portion, and it's extensor tendon disruption, and that's what it looks like. And then you have a boutonniere deformity, which basically is the PIP joint. So the proximal interphalangeal joint is just bent, right? That's a boutonniere. It looks like a boot. And the swan neck is where you've got, a lot of times they'll say, flexion of the PIP for boutonniere, and the swan neck would be extension of the PIP with flexion of the DIP, and that's a swan neck deformity. So just be sure that you understand those, as those are high yield just because they're testable. Acromioclavicular joint sprain or strain, shoulder separation. So you've got that AC joint. There's not a lot of space right there. If you get a direct blow, bam, right to that AC joint, it can separate just enough, and it hurts like heck. And so they call it a bump, but there's going to be swelling and pain, and they basically need rice therapy. So let's look at this. You can grade them, right? So grade 5, 4, and 5, you really want to think about sending this patient to ortho. Grade 1, 2, and 3 usually can be treated outpatient. So here's grade 1. Basically, you don't really see anything. You're looking right here at this AC joint. So the acromioclavicular joint, all right? So grade 2, you might be able to see on x-ray. Grade 3, you're obviously going to see. Grade 4, there's loss of space. And then grade 5. So 3, 4, and 5, they need to see ortho. 1 and 2, we'll just put them in a sling. There's a 5. So grade 1, 2, and 3 are treated non-operative with NSAIDs. I refer grade 3. But 4, 5, and 6, then we need to send to ortho immediately. And they can do an internal fixation. So they fix them up like that. Pre and post-ops, looks nice. Nursemaid's elbow. So nursemaid's elbow is that subluxation of the radial head from that annular ligament. Basically a long traction. So sometimes you'll hear like, oh, my kid was going to fall off the bed and I grabbed him, or he's going to run out of traffic and I pulled his arm. And that's usually the history. At any rate, you got this kid that comes in, won't move their arm, and you need to reduce that. So really what we do is we usually take an x-ray. The x-ray is going to look completely normal. We can't see that annular ligament on x-ray. And just with the history and the presentation, the kid won't use their arm. We're going to reduce it. And so the reduction here is basically you find the radius, so you follow the thumb all the way back to the radial head. You're going to put pressure on the radial head, and you're going to supinate. So you forcefully keep that elbow down by the side, and you're going to supinate excessively. So you flex and supinate at the same time, and you'll hear a little click, and then the child will probably hate you. But then 2 minutes later, you'll bring a popsicle back and they'll grab it with that arm and they'll like you. So it's one of those cool things. There's also another way to reduce it where you start in flexion and you quickly pronate the arm. A little bit harder, but it's basically hypersupination with flexion of the affected elbow. And you have to stabilize with your thumb over the proximal radius. All right. Both bone forearm fractures. So this is your Montegio and Galeazzi. I just use the mnemonic for this. Basically, it's like a bad forearm fracture, but you're going to have dislocation either of the ulna or the radius. So at this case, they're going to need closed reduction. So you do it outside of the body, right? And a cast to stabilize the fractures. So we really need to make sure that we're consulting with ortho on these cases. We're not going to be doing all this by ourselves. So here we've got a mid-shaft radius fracture. Ulnar fracture with dislocation of the radius. So this is Monteggia. So Mugger, M-U-G-A-R. So Monteggia ulnar, M-U. So Monteggia means fracture of the ulna M-U. Monteggia means ulnar fracture, and Galeazzi means radial fracture. So let's look at this. This is a Galeazzi. So you've got fracture of the radius with dislocation of the radial ulnar joint. So let's look at this. Muger, right? So M-U. So Monteggia ulnar fracture, Galeazzi radius fracture. So if you know those, they're really good to know because you get quizzed on them a lot. They're highly testable. So just something to think about. Make sure you tuck in the back of your mind. Tibia shaft fractures. So these are high impact trauma. Often involves the fibula, ankle, and knee. We want to x-ray all of these because these do not fracture unless they are a really high level trauma. You're not going to fracture your tibia from falling down a stair. It's going to have to be like, a car accident or something like that. So the treatment is to check for vascular status. Obviously cover all wounds with a sterile dressing, gentle traction to alleviate or reduce any gross deformity, usually parenteral pain control. So these people are on morphine, Dilaudid or whatever, make them feel better and get them back in place. And then they're probably going to take them to surgery and do an ORIF. Complications, obviously avascular necrosis, avascular injury. You can injure nerves, you can injure vessels. They can result in osteomyelitis. A lot of those things can occur. Compartment syndrome can occur also because you have so much trauma and disruption of the surrounding tissue that you can get this full compartment. So compartment syndrome is treatable by fasciotomy. So basically, if the compartment is too full of fluid, we've got to let it out. And what they do is they basically loosely they open it up, they dissect, and then they loosely approximate it so it can drain. Ankle fractures. So ankle fractures, we need to assess the syndesmosis stability. We can use the Ottawa ankle rules. The classification system utilizing the Weber system is helpful, and a good Mortise view is critical. Consider stress views or comparison views. So we did talk about those stress views. These are the Ottawa ankle rules. I want you guys to be familiar with these. You should understand these. Check out some YouTube videos on the simple Ottawa ankle rules, but they're really just medial lateral malleolar tenderness if the patient cannot bear weight, if they have tenderness over the fifth metatarsal or the navicular bone or the proximal femur, then we should image them. So here's a femur fracture. So what happens is you have like an eversion injury. So you evert here. And what happens is as you evert and sprain this ankle, you fracture this proximal fibula. And I've seen this before. So always press on this site, especially with bad ankle sprains. We want to press up at the proximal fibula because as this ankle comes out, it puts pressure here in these fractures. Here's the Weber classification. So the Weber classification really just looks at the syndesmosis and where the fracture is in relationship to that syndesmosis. So if you have a distal fibular fracture, you want to look at this Weber classification and just classify accordingly. And it just basically goes by A is below, B is at, and C is above. Surgical intervention. So surgical intervention with A, inversion, usually stable with the syndesmosis is intact. So you're going to do non-weight bearing cast and then follow up. B, the deltoid complex is intact, may use closed treatment. So you may or may not perform surgery. And then C usually indicates that the whole syndesmosis is disrupted. And so we need to refer them immediately and have it fixed. And then they can fix it like that. Screws and plates. Woodworking must be nice to be ortho. I want to be ortho. Liz Frank injury. So a Liz Frank injury is a common sports or occupational injury. It's a fracture or dislocation of the tarsometatarsal joint. So typical x-ray shows diastasis at midfoot. So let's look at this. So there's 3 common types. I don't think they're super high yield, but it's basically one that you need to be comfortable with, but it's this fracture, the proximal metatarsal of the 5th or 4th, or sorry, the 1st or 2nd metatarsal. So here's what happens. They'll have some sort of an injury where they see how this is the calcaneus. So basically some sort of high impact or directional force this way, causing the foot to kind of crumple onto itself. And you get pressure and then a force that causes it to go this way. And this completely dislocates or disrupts or fragments. And that ligament is torn. And we need to make sure that that gets lined back up. If there's no dislocation and ligaments are not completely torn, you may treat a non-weight bearing cast. If there is any of those, dislocation or the ligaments are torn, then we need to send them for screw fixation. And there's some other resources out there that I highly recommend this podcast, EM Basic Ortho 123 Review. So the EM Basic podcast is on the App Store, but you basically download the EM Basic podcast, and this gentleman from the U.S. Army, or maybe it's the Air Force, I don't remember. Anyway, he does this ortho review for, I think it's for step 1 and 2, but it's a great high yield ortho review, all common fractures and things like that. It's probably take an hour and a half. Do what you're working out this weekend. You will not waste your here. It's a little more radiology than, and then obviously these YouTube videos and the videos that are on the website will be super helpful. So hope you guys have fun with this weekend. Dive into musculoskeletal over the weekend, and then we will tie a bow on it all over the next couple weeks. And I hope you guys are all doing well. I wish you the best, and take care. Talk to you soon.